And we're live, Sarah.
Good morning, good afternoon, good evening. Welcome to the 9th seminar in the Lancet Gender and Global Health Commission seminar series. And I'm absolutely delighted to introduce Professor Simone Diniz from the School of Public Health at the University of São Paulo, who will be talking today on the topic of gender and maternal health, a topic that I'm sure everybody will look at that title and think, well, surely gender is front and center in all maternal health services. But I suspect that Simone may be disabusing us of that idea as this talk goes on. So my name is Sarah Hawkes. I'm one of the co-chairs of the Lancet Commission, along with Assay El Hajj from Dakar, Senegal, and Pascal Alotti from the United Nations University in Malaysia. For those of you who are watching this seminar live on YouTube, please do put any questions you have for Simone into the chat under the screen, and we'll be able to pass those questions to Simone at the end of her talk. So with no further ado, Simone, over to you, and thank you.
Thank you very much, and I will share my screen now. Let me see. Can you see my screen?
We can. Thank you.
Okay, thank you. So first, I'd like to thank immensely for the opportunity to be in this commission, because I am learning very much, and I hope that you learn at least a bit of what I'm learning from you. And I also want to have a note on translation, not only about my English. I hope you understand it, but as a global health community, you must be used to different Englishes. But also by the fact that Brazil has a very particular public health culture, and sometimes the concepts that we use do not translate as easily. For instance, here in Brazil, we use the concept of collective health, which is an umbrella for public health, epidemiology, preventive medicine, social medicine, community health, social science and health, and etc. So we don't have particular associations. We have one, which is our Brazilian Association of Collective Health. So we try to implement interdisciplinary, transdisciplinary, hybrid dialogue on this. And we have a gender working group since 1993. And one of the characteristics of this movement is that we consider that nothing is merely technical. So it's interesting with the comment that Sarah just did, that it's obvious that gender is within maternal health, but one of the issues is that we believe that this is a very depoliticized area in public health, and we tend to what we call maternal infantilism, which is, I'm gonna talk a bit about this on how essentialism, gender essentialism is imprinted in our practice. So the idea is that these so-called technical aspects of clinical care, epidemiology, or public health planning establishes and make explicit social relations. So you can read social relations on how the technical is organized in healthcare. And this is Cecilia Donangelo, a famous author on this. She was talking about social class, but we think that this applies to gender, racism, whatever. So some notes for this dialogue. I will talk a little about what we understand about gender and essentialism in healthcare and in public health. And I'll tell a story, the story of Mari. This is a real and public story to talk about the following issues, which is first a case study of some progressive change, because we will also call it to talk about positive change as case studies in our papers and previous conversations, the issue of evidence production, the change in care, and the challenge of the implementation, how to make gender abuse visible in healthcare visible, the issue of gender blindness indicators and in data science, and who will create the data that we need, who are our potential allies, and what is the scope of gender in global health. So what do you mean by gender? We had such a rich discussion up to here. So I will start very briefly with the rich diversity of social translations of the so-called natural, understanding that there is no ultimate biology to be found, but narratives about this nature and this biology. We understand that sexual diversity is a very important issue. And recently we have lots of students working on trans men, parenthood, and lesbian motherhood, and so on. This is a very relevant and innovative area that deserves a specific seminar on that, but we will not deal on this aspect. We deal on the issue of deconstructing women and women's body, health, care, etc., to talk again about women without the diversity of womenhoods. So we believe that when we talk about essentialism, this reduction to the biological, to the nature, we have two different essentialist explanations. One of them is the essentialism of the mother nature, this idea that women are born to be mothers, they know all, there is an instinct. Now, it has to do, this is very present, including social movements today, with the hippie tradition and naturalist communities, many religious community also, and this is the counter-hegemonic version of the nature. The hegemonic, the dominant one, the one who orients the medical industry, is the narrative of the biological tragedy of womanhood. Women are defective, they are dependent, and frequently we buy medical misogynistic discourse very easily, what we call the correctional approach. The idea is that women's bodies is incorrect and has to be corrected. So recently, especially young feminists are bringing the idea of women's health, and we discuss about the issue of strategic essentialism that recognize the limitation and contradiction of essentialist discourse, gender essentialism, ethnic essentialism, etc. And there is a defense of strategic essentialism that should include this diversity of women's experiences, and the struggle for policies that take into account these particularities, including Black, lesbian, trans, indigenous, etc., these different forms of feminism. This is why we will use the word woman here, women, etc., women's health and women's body. We are very much pushed by our younger generation of feminists who are also revisiting very much the idea of integrality on women's health. So there's a whole effort for this younger generation to recapture the ideas of the public health feminist agenda from the 80s. That's called the Program for Women's Integral Health. So this idea of integralidade, of comprehensiveness, is a very broad agenda, including sexuality, sexual diversity, race, violence, a very strong critique of medicalization, self-help, mental health, aging. It drinks very much with the international feminist movements. So when we say that we buy this essentialist correctional process, a whole industry on this. The idea is that women's body is defective and benefits from routine correction. So the direction of gender bias and blindness that appears in the indicators and even in the clinical records or in the design of research is the overestimation of the risk and discomfort of the so-called physiological birth. I put the quotes. The overestimation of benefit of medical surgical interventions, the underestimation of risks and discomfort from interventions, And there are blind spots on indicators related to what we have been calling the pessimization of the experience in iatrogenic heart. And so we have a profound contradiction between evidence and practice, and a refusal to change by institutions. So I'll tell the story of Mari. So Mari is a Black woman in her mid-20s, pregnant with her second child. And she goes to one of the training hospitals of a famous university. So I don't know about your countries, but in Brazil, training hospitals use patients for training purposes, regardless of medical need for intervention. So for instance, in Brazil, the first opportunity to cut and make a suture for medical students, at least it was my experience in medical school 35 years ago, and it's still what happens, is in the vagina of a poor woman in the public sector. So during her birth, she is assisted by several unidentified trainees, and she gets 2 episiotomies that's cut in the vagina, one in each side of her vulva. And she understands that she had it to provide 2 opportunities for students to train their surgical skills, the incision and the suturing. As you may know, in some training programs, trainees have to have a number of interventions opportunities. So she believed that this is unacceptable and made a formal complaint to the Ministério Público for obstetric violence. The Ministério Público is I don't know, we have different judicial systems. So this is where you can make a formal complaint for your rights being violated. So the question would be, why was this woman having an episiotomy? So thinking in terms of gender, we have these irrational interventions that are based on gender sexual culture. The idea that male sexual terrors are treated as science, and birth is described as an inverted rape. So we learned that this quote here is from the book that I studied. That's another version, different years later, saying this, that when the baby passes through the vagina, there is going to be a reversible laxity of the pelvic floor. So you should cut, women, and then sew and do so-called husband stitch to make women like virgin again. So you see here in your right side, this is a direct action by the network of women against episiotomy, asking women to demand for informed consent for that. So why we could ask, because what's the reason why Mari had an episiotomy, indeed, 2 episiotomy? Because medical practice is frequently irrational, and the struggle that women have to change this practice and against violence in healthcare is an old one. So I'll give an example of innovation, and I make my small tribute to the Cochrane collaboration, dialoguing with the idea of evidence, because these people started to build what we now understand as systematic appraisal of evidence. They created the methodology for systematic reviews in the perinatal epidemiology group in Oxford. And this was very much pushed by social movements against routine episiotomy, especially in UK, but also in other countries there in the 80s, that they made the first randomized control trial about episiotomy happen. Otherwise, they would not be. And the first one was in 1981. We had the 2 first clinical trials, and by the end of the 80s, we already had systematic reviews about episiotomy. So this kind of evidence production, it was very much infiltrated by feminist activists. And I hear my small tribute to Murray Ankin, who was one of the activists for this. He was also an activist for the relegalization of midwifery in countries where it was illegal. And this led in the 90s, and the Cochrane Pregnancy and Childbirth Group had a very important, it was very important internationally. And these books, such as the Guide to Effective Care in Pregnancy, that was directed also for women, not only for providers, with the language that women could understand, and the Caring Normal Birth, a Practical Guide by WHO, they became a source of strength for movements locally to fight for change in healthcare. So the evidence-based discourse was very aligned with the idea of rights, with a lot of feminist infiltration, let's say. This had limitations, of course, but the pre-description of nature was had a lot of potential for strength. So all around the world, there were initiatives. In Brazil, we have very strongly this idea of the humanization of childbirth and so on. And this letter that was published in the Lancet in 1985, it was very important. And this is to stress how long it takes for a practice to change, since you have evidence, until what really makes this investment and this implementation happens. So lots of coalitions use this idea of evidence. So, and this evidence was also important to explain what's the reason why women had so many cesareans in Brazil, because birth experience was this experience of violence. So there was a lot of debate about this, use of human rights, and a lot of initiatives. There were also international initiatives about creating new indicators, new names, and expanding epistemic freedom for women to talk about their experience with childbirth care. So the other issue that's very important when you think in terms of gender is the agenda of trainers. For instance, we do not teach only techniques, we also teach values. We talked about this in the previous seminar, and the presence of training is not the problem, it's the lack of regulation of this. Because when we make do episiotomies, or we use women as training material, we are putting them not in the human condition. So this is what frequently we are teaching our trainees. So because there were so much social movements and people went to the streets, and there were so many demonstrations, there were these audiences públicas, there was public audience to discuss the issue and try to change the indicators. So there were several agreements about changing practice, and a list of indicators were created that were not there before. So on episiotomy or peritoneal state after birth, companionship, choice of position, right to choice of place of birth. Some of these indicators, they are more objective, and some of them depend on what we call the third layer of indicators. And this depends, the methodology to get to it is different, and we believe we have three layers. One is the live birth certificate data. The second one is medical records and service, etc. And the third one that asks for things that are invisible to this system, such as freedom from abuse, fungal pressure, false information, baby safety that has a huge impact on women's compliance with all kinds of abuse, the right to informed choice, etc. So developing this layer of indicators is one of the challenges. So inspired here on the use of anger, modulo here, can we turn our sense of injustice and our anger into an indicator? So I'm calling here for, why did Mari speak up? Because she saw this movement, she saw this subversive communication about choice, etc. And this turned into a movement that turned it into new indicators. So this is the issue of the epistemic power of the sense of injustice, the issue of the narrative we have about childbirth is epistemically unjust. We need new narratives, including new narratives of the biology, to understand gender violence in medical knowledge and decolonize maternity care. One of the issues, the right to bodily integrity and to genital integrity. And midwifery has a huge potential in terms of decolonizing knowledge. Childbirth can also be understood as a sexual and reproductive health and rights, part of the human rights agenda. So let me take this, what I want to show here is from creating these indicators about if women were mobilized, if they had the membranes rupture, or the position if they had episiotomy, if they had fundal pressure, we created indicators and comparing the data, national data from 2011-12 and 2017, in this interval of 5 years, we had an incredible change in the use, in the increase of good practices, in the decrease of bad practice in childbirth, because this is now being monitored. So I will run here, but the Lancet and other publication and institution are working with this idea that we have both the problem of too late interventions, where women receive care that's not timely or sufficient, and also the too much too soon, the issue of over-medicalization, and in poor countries or low and middle-income countries, we have the worst of the two words. We have also the short and long effects of the excess of intervention, from admission in intensive care, neonatal intensive care, to chronic disease, to readmission in the first year, etc. And we need to have appropriate indicators to make this visible, including the issue of the conflict of interest with the medical industry. So one of the issues is overuse, over-medicalization, over-diagnosis, over-treatment, an issue in global health, and the issue of disinvestment as innovation, because we have to face the commercial determinants of health and disease. And to have a more gender-friendly care, we need to disinvest. We need to create opportunities. And one of the issues also related to strategic essentialism is the new insights on the biology of childbirth, bringing the issues of epigenetics of labor and the role of going into labor into protecting for non-communicable diseases, mode of delivery and the formation of the microbiome. So we need indicators such as pregnancy day lost, antibiotics use, and breastfeeding rates in the first hour, etc., to see both the effect of the health of the next generation for this with these long-term cohorts on diabetes, obesity, cancer, allergies, etc. So who will create the indicators that we need? For instance, rate of bodily genital integrity. It is a composite indicator about not having cesarean, no episiotomy, and no lacerations, treated with perineum with respect, the right to go into spontaneous labor. That's an indicator that's being refined now, and pregnancy days lost, not only for preterm, but also for term period, because it has huge effects both in mother and babies. This is an analysis that we recently did. This is the term period here, and see the difference in mortality. And here, this part, we have different patterns, because in this part, you see the excess of interventions when you go over 39 or 40 weeks, because people believe that the baby should be born before 40 weeks. So we have also this paradox. The more intervention, the more the days lost. So the worst of the two words is having the intervention, the effective intervention, and being poor. So to finish, midwifery is a very interesting gender strategy, and I bring this from the Follow the Data, Invest in Midwives, that's been very much disseminated, bringing the issue of gender disparity. So how can we synergize with midwifery, for instance? Because midwifery knowledge has to be gender sensitive, and it's based on medical knowledge, which is very westernized and male centric. So all the issue of decent work, decent pay, equity, and midwifery can be even understood as a form of reparation for women and all the people within the country having access to more prestige, money, reputation, and so on. Well, the political context, I told you what about what situation before we started. And we even have a political divide over birth. Spontaneous is left-wing, feminist, dirty and disgusting, while cesarean is clean and civilized, and so on. So here you read. So it was a demonstration against the government. Cemetery is full and fridge is empty. So the last slide here with my little tribute to Murray Ankin, who died these days, who was a great champion for evidence. He moved obstetrics from the rear of to the forefront of scientifically based clinical disciplines. And this has to do with our story with Mari. He was one of the champions about this. So some of the questions for us, and I'm here. Pascal said in her presentation that she fears that she doesn't have the answer that are expected from her. I don't have the answers, and I also have some questions to share with you. Not to have these are not easy answers, but what about the issue of gender and conflict of interest? For instance, industry versus evidence, medical versus other health workers' rights, the issue of medical overuse, the international influence, both positive and negative, because I have mentioned very positive influences also. So the difference between the international and the global, what would be the alliance and synergy? And I will invite you, but not now because I want to finish my presentation, about comparative studies that we could do in this issue. Thank you so much for your attention.
Simone, that was fantastic. What an incredible sweep of both the history and the current practice in obstetric services. And I mean, I think you've captured it incredibly deeply for one setting, but we know that these problems are not unique to one setting. They're global problems. Whilst we're waiting for a couple of questions to come online, I wonder if I could ask you to reflect on something that you raised a number of times during your talk in relation to, you phrased it as the conflict of interest, but of course there is a direct interest in terms of the money to be made from the medicalization of women's bodies. And we see this not just in obstetrics, but in the growth of sectors such as the wellness industry and the push for women and wearable technologies and women and nutritional supplements and whatever. I wonder if you could just reflect on us what we can learn from what worked in, or what is still working in the field of obstetrics to other areas of women's health, to challenge the notion to challenge that conflict of interest.
Well, I don't know much about the well-being industry, but two of my favorite issues are contraception and cancer screening, to use this idea of the biological tragedy. this essentialism. And contraception is a very interesting issue because we have less options in terms of contraception now than we have in the 80s, for instance. Barrier methods disappeared, you know, female barrier methods. We had diaphragms, we had female condoms, and there was a culture of using this among, you know, people I knew. And now it's almost impossible. And even the WHO changed the classification of contraceptive. Now the distribution is oral contraceptive, injective contraception, long-term contraception, implanted contraception, IUDs with all of these are hormonal, you know? And we have less and less, especially in a country where abortion is illegal, you know? Younger generation are now demanding the right to ovulate, to have a cycle, you know, because nobody is entitled to anymore, you know. It's just like go into labor. For instance, one of the issues that we want to make visible, we're doing a lot of work with several layers of information, is go into labor. The other issue is cancer screening. And I will call the attention, the Lancet recently published an issue of a paper where I was reading about thyroid cancer overdiagnosis. It's so outrageous, you know. They calculate the 80%. This is a gender issue because women are much more exposed to thyroid cancer screening because they go more to the doctors and they keep making ultrasound of the, so you have no change in mortality, but incidence has increased several times, you know, so there's a whole industry related to inventing, you know, increasing the patient pool of patients for tests, for hormones, for etc. I don't know if this is an interesting overdiagnosis and overtreatment, you know, in terms of a gender, because more than one of the seminars, people said, well, we're talking about inequity, inequalities, etc., but women live more than men, you know? This is women turn into even more of the patient pool for these industries.
That's a very provocative thought to leave us with, Simone. So I'd like to thank you again for a really, really fascinating seminar. We're going to close the public screening now, and thank you for everybody who's been watching, and do please read the blogs on the UCL and the UNU websites, which will be coming